Hello, everyone. My name is Afeni Morris. I am a graduate student at Nicholls State University in the Education of Nursing program, and I'm going to discuss with you the inflammatory bowel disease. So, what is inflammatory bowel disease? It's classified as a chronic illness that causes digestive disorders and inflammation in the gastrointestinal tract. It's divided into two parts: ulcerative colitis and Crohn's disease, and I'm going to break those two up and discuss them separately. So, what is in discussing the two parts of inflammatory bowel disease, I'm also going to include each part's pathophysiology. The mucosal inflammation of ulcerative colitis usually includes the large intestine and the rectum. It results from a defect in the epithelial barrier, immune response, leukocyte recruitment, and microflora of the colon. The epithelial barrier has a defect in the colonic mucin, resulting in increased uptake of luminoantigens. Atypical T cell or T helper cells in people with ulcerative colitis exert cytotoxic responses against the epithelial cells. Immune-related factors in ulcerative colitis include tumor necrosis factor A, interleukin-13, and natural killer T cells. In leukocyte recruitment, there is a upregulated release of chemoattractant CXCL8 and upregulation of mucosal adhesin cellular adhesion molecule 1. Studies of the esoteric microflora allows for the determination of pathogenesis and the severity of the inflammation of ulcerative colitis. And so in this slide, I give you a kind of a picture of what the pathophysiology of ulcerative colitis looks like. So now we move on to Crohn's disease. Crohn's disease can cause inflammation in any part of the digestive system, such as the large intestine, the stomach, the esophagus, the mouth. In Crohn's disease, there is tissue inflammation, and it's caused by uncontrolled immune response against luminobacteria antigens, which is pretty much similar to ulcerative colitis. Immune cells such as CD4 T cells and CD8 T cells infiltrate the stomach. Innate defense mechanism causes infectious disease and intestinal mucus secretion. Molecules mediated by bacterial adhesion, such as FUT2, are responsible for secretions of soluble forms of ABO antigen. Variance in FUTS decreases the secretions of ABO antigen and alters interaction with bacteria, resulting in more susceptibility in the development of Crohn's disease. And again, just like with ulcerative colitis, there's a picture of the pathophysiology of Crohn's disease to give you a better idea of what it looks like. The etiology of inflammatory bowel disease is relatively unknown still. It appears to occur in genetically susceptible individuals after an immune response to the intestinal flora. A strong link between Crohn's disease and tobacco smoke exists. Its proposed mechanism that explains the role of tobacco in Crohn's disease includes mucosal damage, changes in gut irrigation, and impaired mucosal immune response. Smoking appears to protect against ulcerative colitis, interestingly enough. Studies show that the risk of suffering from ulcerative colitis is significantly lower in people who smoke compared with non smokers. Additionally, relapse rates and hospitalization and the need for potent drugs are significantly lower in people who smoke. Now we're going to discuss the characteristics of ulcerative colitis. So one of the characteristics is diarrhea, which may consist of blood. There also may be frequent and small volume of diarrhea when there's rectal involvement or rectal inflammation. You might have colicky abdominal pain, urgency, tenesmus, which is feeling like you need to pass stool when it's already been empty, and incontinence. Distal ulcerative colitis may have constipation accompanied with frequent discharge of blood and mucus. Symptoms can be gradual or progressive over several weeks. And depending on the severity of ulcerative colitis, abdominal tenderness on palpation, fever, hypertension, and tachycardia could occur. So we have the characteristics of Crohn's disease. With Crohn's disease, you have crampy abdominal pain. There's also persistent but intermittent diarrhea without gross blood, and features such as skin, eye, and joint problems could occur. There is systemic symptoms such as fatigue, weight loss, and fever. The weight loss mainly comes from a lack of absorption, specifically from the small intestine. Fistulas can occur, which are transmural inflammation associated with sinus tracts that may penetrate the serosa, giving rise to fistulas. You have the phlegmon and the abscess, which is localized peritonitis with fever, abdominal pain, and tenderness. You could also develop, which I see often, the perianal disease, which is perianal abscess is characterized by perianal pain, fever, and purulent drainage. And then there's malabsorption. Again, with small intestines Crohn's disease, presentation may be watery, diarrhea, staturia, which is fatty stool, leading to protein calorie malnutrition and vitamin deficiency. Diagnostic tests for diagnosis of ulcerative colitis. So we have stool tests. A lot of times stools for C. diff, for E. coli, over and parasites, 3 samples. Body and stool antigen tests are done. These tests are also done for people who have traveled to endemic areas recently. We do tests for sexually transmitted infection for particularly men who have sex with men or people with severe rectal symptoms. Endoscopy and biopsy are done. Findings in patients with ulcerative colitis are non-specific. Biopsy of the colon are obtained to establish chronicity of the inflammation and to exclude colitis. Biopsy features that are suggestive of colitis are crypt abscesses and epithelial cell abnormalities. They have inflammatory features, lumina purpura, celerity, basal plasmacytosis, and basal lymphoid aggregate. Diagnostic tests for the diagnosis of Crohn's disease. So you will likely see doctors order a CBC. They're usually checking for anemia. CMP, checking for electrolyte imbalances. Serum iron level, vitamin D, vitamin B12, and C-reactive protein. With the iron level, I normally do the small bowel endoscopy at my job, and almost always The doctors will order a small bowel endoscopy if they can't find the source of low iron or bleeding from the upper scope or the lower scope. The small capsule endoscopy is a pill that they swallow, and it looks at the small intestine so we can see if there's any bleeding, any Crohn's disease in this case, in that area. They also order stool tests such as C. diff, ovarian parasites, fecal calprotectin, which is the same as ulcerative colitis, and I see these tests ordered often. They do an endoscopy, colonoscopy with intubation of the terminal ileum. They prefer, endoscopists prefer, when a colonoscopy is done, that it's done all the way to the end of the colon and right at the start of the small intestines, which is the terminal ileum, because they want to make sure that there's no disease process in those areas. And if you're new to, from my understanding, if you're new to scoping patients, or the patient has maybe an odd or a different shape large colon, doctors were not always able to get to that part, and it could definitely have some abnormalities. And so when they do the colonoscopy to the terminal ileum, they're checking for fecal ulcerations adjacent to areas of normal appearing mucosa, nodular mucosal changes as well. Intermittent areas of normal appearing bowels interrupted by a large area of disease are commonly seen in colonoscopies for patients with Crohn's disease. Biopsies. They are obtained from the disease and normal areas for histologic evidence and inflammations. Findings include focal ulcerations, acute and chronic inflammation. All right, now it's time for some review of some of the things I presented. We'll start with what is inflammatory disease. All right, so now we're going to do. Okay, and hopefully you guys remembered that inflammatory bowel disease is classified as a chronic illness that causes digestive disorders and inflammation in the GI tract. It's divided into two parts, which is ulcerative colitis and Crohn's disease. Okay. Next question, what are the clinical characteristics of ulcerative colitis? Is it A, constipation or swelling of the abdomen? B, right upper quadrant pain and nausea? C, rectal bleeding and abdominal pain? Or D, colicky abdominal pain, diarrhea, and bowel incontinence? All right, the answer is colicky abdominal pain, diarrhea, and bowel incontinence. Right. What are the clinical manifestations of Crohn's disease? Is it A, colicky abdominal pain, diarrhea, and bowel incontinence? B, diarrhea with abdominal pain radiating to the back? C, intermittent diarrhea, weight loss, and fistula? Or D, left upper quadrant pain, fever, or bloody stool? Okay, and our answer is intermittent diarrhea, weight loss, and fistulas. It can also have an abscess. Last question, guys. What are common diagnostic tests for both ulcerative colitis and Crohn's disease? Is it A, CT scan, MRI, or X-ray? B, abdominal biopsy? C, stool test, endoscopy, and biopsy?